I hereby open this academic ceremony in which Silvia Thomann will defend the academic thesis Restraint Use in Somatic Acute Care Hospitals. Do we need to care? May I invite you to present a summary of your study and the conclusions of your thesis.
Highly esteemed Prorector, highly esteemed opponents, dear colleagues and friends, welcome to the presentation of my PhD thesis about restraint use in hospitals. The first association that many health professionals make with the term restraints are fixation with a belt. However, as the definition shows, it includes much more, for example, also electronic observation or medication. It is evident that restraint use leads to negative effects for patients and health professionals. Therefore, a reduction in its use is recommended for all healthcare settings. From a theoretical point of view, it is known that restraint reduction must be stimulated at different levels. That means it is often not enough to improve staff knowledge in direct clinical practice. Effective restraint reduction requires improvements across all the different levels. For example, a clear framework is needed at the healthcare system level or adequate structures within institutions. Such effective multi-level approaches are mainly known from the mental health and long-term care setting. However, also with regard to macro-level initiatives, they are most often focused on mental health and long-term care. For example, in many countries, the legislation is much more explicit for the mental health and long-term care and rather implicit for the hospital setting. But also other macro-level initiatives like national monitoring for restraint use is most often only established for mental health and long-term care. In contrast, for the hospital sector, recommendations exist. However, there is limited evidence about their implementation and effectiveness. In general, there was a limited research attention on restraint use in hospitals. Few studies investigated restraint use, and most of them focused on subpopulations like intensive care and included only mechanical restraints. Thus, restraint use in hospitals might not be understood comprehensively so far, and this might lead to the fact that effective restraint reduction strategies are still lacking. Therefore, this thesis aimed to comprehensively describe restraint use in the hospital setting and thus to add knowledge for the identification of effective restraint reduction approaches. For this purpose, 5 studies were conducted in which restraint use was investigated independently of subpopulations and restraint type. These studies I like to present you now. The first study aimed to investigate restraint use, including restraint type, reasons for restraint use, processes surrounding restraint use, and patient characteristics associated with restraint use. For this purpose, a cross-sectional multi-center design with descriptive and regression analysis was performed. Based on the data of almost 30,000 patients from 140 hospitals in Switzerland and Austria, we found that almost 1 in 11 patients is restrained during hospital stay. Most often, restraints are used to prevent falls. In general, we found that a vulnerable patient group is most affected by restraint use. We found that the most strongly with restraint use associated patient characteristics are care dependency and mental and behavioral disorders. Even though restraints are frequently used in hospitals, the required ethical and legal processes to ensure that restraints are used only as a last resort are not implemented systematically. For example, only 2/3 of all restraints were documented in the patient file. All other processes like evaluation to stop restraint use as early as possible or alternatives to minimize the use of restraints are even less often implemented. For the second study, the same data set as in study 1 was used. This study aimed to examine variance in restraint use explained on the hospital level and the impact of organizational factors on restraint use, both considering the different patient mix. Here, descriptive and multi-level regression analyses were performed. First of all, we found that the availability of the investigated organizational factors varies widely. While almost 75% of patients are treated in a hospital where a guideline regarding restraint use was available, for only around 20% of patients, nursing staff attended a refresher course in the past 2 years. Only these two mentioned organizational factors were found to be associated with restraint use, more precisely with less restraint use. The other two investigated organizational factors, no statistical association with restraint use could be found. Regarding the variance in restraint use, we found that 24% can be explained by the patient mix and the mentioned organizational factors. If then the hospital is added to the regression model as a so-called random effect, the explained variance increases to 55%. This means, on the one hand, that there must be other, not measured, and potentially also hardly measurable conditions on the hospital level that influence restraint use, for example, the institutional culture. On the other hand, this indicates that similar patient situation might be treated with restraint in one hospital, while in another hospital no restraints would be used. The third study aimed to describe daily restraint practice and their influencing factors from an outsider's perspective. For this purpose, a qualitative observation study design with interpretive description was performed. Based on 67 hours of observation, we found that the broader understanding of restraint is still poorly established in hospitals. For example, relevant differences in the standardization of processes were identified, while for fixation with a belt, processes like documentation, evaluation, but also interprofessional discussion took place in a standardized way, almost no standardization was observable for other restraint types. This lack in standardization might also be related to the second main finding of this study. Restraint use depends on individual and intuitive decision of nurses. Thus, it might be that one nurse would use restraint in a certain patient situation, while another nurse would manage the situation without restraints. However, also many approaches were observed that potentially reduce restraint use. These approaches most often involve taking the patient's perspective, for example, by recognizing that the patient is overwhelmed with the situation in the hospital and thus starting to communicate more proactively. However, here too, there was hardly any standardization observable, and these approaches seemed hardly to be used purposefully for restraint reduction. The fourth study aimed to assess nursing staff's attitude and to test the construct validity and reliability of the Maastricht Attitude Questionnaire. For this purpose, we used a cross-sectional design with descriptive, regression, and factor analysis. Based on the data of 180 participants, we found that the MAQ can be used in the hospital setting with minor adaptation, even though further testing is recommended. Regarding the attitude, we found that nursing staff has a rather neutral attitude towards restraint in general. This means that nursing staff is neither very critical about restraint use nor favoring restraint use. In addition, we found that nursing staff perceives the discomfort in the use and the restrictiveness of restraints for patients as being moderate. However, big differences depending on restraint type were evident. The more obvious a certain restraint type restricts the free movement of a patient, the more nurses perceive discomfort in their use, as well as perceive them to be restrictive for the patient. The last study focused more on the macro level. It aimed to assess the potential of restraint use as a national quality indicator for the hospital setting. For this purpose, a secondary data analysis with multi-level regression analysis was performed. The sample consisted of almost 19,000 patients of 55 hospitals in Switzerland. In this sample, almost 1 in 10 patients were restrained during hospital stay. Here we found that 40% of all hospitals used either significantly more or less restraint than the average, even after adjusting for the different patient mix. Compared to other quality indicators, this is a very high value. For example, in Switzerland, falls and pressure ulcer are measured with the same data collection method and analyzed using a very similar method. And for these two quality indicators, the range of outliers lied between 0 and 8% over the past years. Thus, in restraint use, there are big differences in quality of care, and therefore, national monitoring of restraint use in hospitals in terms of a national quality indicator might be an effective macro-level restraint reduction approach. In conclusion, this thesis showed that restraints are frequently used in hospitals and affect a vulnerable patient group. This is a group of patients that is often unable to stand up for their rights themselves. Therefore, it is even more important that everything is done to ensure restraint use as a last resort. In addition, differences between hospitals and between nurses appear in the use of restraints in similar patient situations. Such differences should not exist from ethical and legal points of view, but also from professional and social perspectives. However, these differences also point to the fact that a reduction in restraint use is possible. In this way, this thesis clearly shows that there is potential for stimulating restraint reduction across all levels of the healthcare system. Therefore, the answer to this thesis title is yes, we need to care about restraint use in hospitals. Thank you for your attention, and I now like to give the word back to the prorector.
Thank you very much for the clear presentation. It's now time to start with the opposition, and the opposition will be opened by the chair of the assessment committee, Professor Hamers. Professor Hamers is Professor of Care of Older People at Maastricht University.
Thank you, Mrs. Prorector. Dear candidate, I think you have written a very interesting thesis. You've conducted very interesting studies. It's an important topic, restraint use in hospitals, and you probably know, I think it's also important because we have a research line at our university. It's an important research line and our living lab. So, herzlichen Glückwunsch with the end result. So congratulations to you and the supervisory team. Just before we were waiting, we were discussing informally with some colleagues the illustration on the cover of your thesis. And we were thinking, hey, where are the restraints? And somebody said, well, probably this is the end goal, or this is the goal, to be restraint free. But could you please elaborate? Because we were a little bit confused. We were searching, but we didn't see any restraint on the cover.
Highly esteemed opponent, thank you very much for the compliments and the question. Yes, the cover, I choose this one because I think it's all about humans, and this cover was a nice symbol to show that there are different humans that are also that suddenly can become a patient in hospitals, and all of them like to be treated without restraints, and also to show that we all need to care about restraint use. So it's not only a topic for health professionals, it's also a topic that should be addressed by the government, for example, or that anyone should be interested in, because, as mentioned, suddenly everyone can become a patient or a relative.
Okay, thank you. So now all of us knows what the cover is about, actually. So my first question is actually about the prevalence studies, because I would like to elaborate a little bit on that. There was one study presented in chapters 2 and 3, I guess, and one main finding in chapter 2 was the difference between countries, Switzerland and Austria. So in Switzerland, the risk at restraint is about 2.2 times higher than in Austria. It's correct, eh? Yeah, is it?
Based on the prevalences, yes.
Okay.
It seems like this, but I think you will come to this point, because we couldn't see this difference.
I was wondering why did you not mention that in the abstract of the paper?
Why you didn't mention the differences?
Yeah, that there was a main finding on country, actually.
Yeah. the aim of this study was more or like more on a comprehensive description, and the comparison of the countries wasn't the focus.
Okay,
so it was more like an extra information for the reader if they are interested, but it was not the focus of the paper, because as we know from quality of care, and especially when comparing prevalences, there we know, if we are in this topic, that comparing prevalences is always difficult, because we never know whether it was exactly the same population investigated.
Okay, but I thought it was a main result, so at least that took really my attention directly when I read the paper. And I thought, well, probably you would like to recommend that people who would not like to be restrained better should go to Austrian hospitals than to Swiss hospitals. But that's not correct.
No, it isn't like this. And what I also discussed in this paper is that even though the prevalences are very different, when we have a closer look what kind of restraint was used, we can see that in Austria they might be a bit more restrictive than the ones in Switzerland.
It's only the belt restraints. All the others were in favor of Austria.
Yeah, but we could see, for example, that there are more closed wards or hospitals compared to Switzerland. But yes, it wasn't it wasn't the aim of this study to compare countries, because I see many difficulties in comparing.
Okay, could it be the case that there isn't a country effect at all?
Sorry, I didn't understand this question.
Couldn't it be the case that there isn't a country effect at all? So I'm wondering, in the next chapter, chapter 3, you are introducing a new factor, a new determinant, and that is hospital.
Yeah.
And I was wondering, because it was not mentioned in chapter 2, and hospital was a very important factor. There was a large variety. Actually, it was also supported by your last chapter, and you replicated or different data, different sample, and I saw the same. There was a large variety, and I was wondering if you would have included hospital as an important factor in the analysis of chapter 2. Could it be probably, well, I'm not sure about that, but could it be that you wouldn't have found a country effect?
Do you mean that I would have included, or that I would also perform a multi-level analysis in chapter 2? Right?
Yes, and you would have corrected for the hospitals.
Yeah.
Or do you say, well, that probably, well, it's just a question.
Yeah. The focus of chapter 2 was more on describing just what happened, and which patient is most affected, independent of this hospital factor. So there were two different aims of these two studies, and we were how to say, I first thought about including also the structural characteristics in study 1, in chapter 2, but then I realized that would be way too much for one publication, because these are different questions. The one was more focused on the micro level, and the other included also the meso level, like the structures within an institution, and also the hospital effect itself. And what we also know is that for people reading this article, or I hope that they read it, that such multi-level approaches are still not well understood by many practitioners, but also by some researchers when we can read comments on it. So it might also be easier for them to understand a study only using just a normal regression analysis than a multi-level analysis. But when I would have to do it again, I might consider to do a multi-level analysis also for the first study, because we saw then that there was that this hospital effect is so big. So I think in this regard, I learned a lot. But when I started, we had different views on the things.
Okay. I'm looking at the prorector.
You have 1 minute.
Okay. Then my last question would be about, again, the hospitals, but then from a different perspective. Actually, what I would like to know is, do we know what the characteristics are of the hospitals with the low prevalence numbers? In other words, what can we learn from these hospitals? Because this is a little bit the question, at least when I heard your introduction, you would say, well, we'd like to reduce the number of restraints. So what can we learn from them? Do you have information on that?
I do not have information on that. I think that would be a very important topic to investigate further, whether this is really the institutional culture, or I think there were also some predictors missing, like the nurse-to-patient ratio that couldn't be included, or also skill mix that might be important.
Okay, thank you.
Thank you very much. The opposition will be continued by Professor Möhler. Professor Möhler is Professor of Health Services Research at the Heinrich Heine Universität in Düsseldorf in Germany. Glad you're here. The floor is yours.
Yes, thank you very much, and thank you very much for the very nice presentation and your very interesting and well-conducted thesis. I was very impressed about the big number of studies in a setting where we have not enough research. So I think it's the very perfect time going to this setting. And maybe at the point where we ended with the last question, I would like to focus on the attitudes, because you talked about culture, and you have one aspect beside the prevalence, you have the attitudes which you have measured. Can you elaborate a little bit why you have focused on the attitudes?
Highly esteemed opponent, thank you very much for the compliment and the question. When I understand your question correctly, you are addressing chapter 5.
Yeah.
Yes, we investigated also the attitude of nurses, because we know that attitude is an essential factor in any decision-making process. And so far, attitude was investigated most often in mental health nurses or nurses working in long-term care, but data on the attitude of nurses in hospital care was missing so far. So we didn't know whether they are really favoring restraint use, because that could be expected when we see also the prevalences, or also know how practice works, that there are in many hospitals also kind of implicit standards that, for example, a patient that is intubated must be also fixated, or must be the hands fixated. So yeah, this was the reason.
Okay, thank you very much. I'm a little bit critical regarding the validity of attitudes in the context of predicting the use of restraints. So I think we have several studies assessing attitudes, and from my point of view, the link between using restraints and the attitudes is very weak. And so I'm very interested if you think that attitudes can be a predictor of restraints use, and how big do you think is the political filling out of the instruments? So maybe people know what they should answer, and maybe they answer because they think this should be the right answer, but it's maybe not reflect their personal view.
Yes, regarding the first question, whether this is really predictive, that it would be very interesting in further studies to investigate whether the personal attitude and also the institutional culture are related, because there are indications available that the performance of staff and also the way they are thinking about restraint use is closely related to how restraints are handled within their institution or ward. So it might be that this is even more important than the individual attitude, because nurses, as we are socialized in a way, and this and the workplace is one place where we get socialized. And regarding the second question, it's more about the instrument itself, whether this is really helpful to measure attitude, or how was the second question to understand?
I'm not sure whether nurses really mark what they think or mark what they think they should mark in these instruments, because of course they know, they read everywhere restraints are not good for fall prevention. They read everywhere restraints have several negative effects. However, in practice they often use them, so maybe they fill the instruments maybe how they think they should feel it and not really how they feel it.
So that we get more kind of social desired answers than the proper answer, what they are thinking about. Yes, this is one limitation in asking the nurses themselves what they are thinking about. However, then, I think it could be a mix, because when it would be only social desired, for example, we would think that the result would be more that they have a negative attitude, so that they are more critical about restraint use. And even though we found that it's that they are neutral, kind of. But yeah, I totally agree with this comment, because we, in other studies conducted in long-term care or also psychiatric care, there were results that it's also really difficult to change attitude of nurses. So this might be related to this comment. Yes.
Okay, thank you. Maybe one last question on this topic. If you will do your next study, or someone other will do a next study, will you say that assessing the attitudes is a good thing, or would you say maybe try about thinking on other concepts which maybe represent better the cultural aspect of the organization?
I think we have still some limitations with the instruments, so what we also could see when we looked at the statistical parameters. So therefore I would say this is one limitation of the instrument itself, so that question whether it is really worth using this instrument and measuring attitude. But as mentioned before, I could imagine, based on the findings of this thesis, that there are other things that are more important, like the institutional cultures, where it would be valuable to get a deeper insight from different perspectives, for example, also from other professions, like physicians, but also the patient and relatives, so that we can get a better picture of this institutional culture that might be more important than the attitude of an individual nurse.
Okay, thank you very much. I think there are some minutes left, but I will give it to the next person.
Well, if you want, you can ask one more question. That's okay, but we can also go to the next. Okay, thank you. The opposition will now be continued by Professor Faber. Professor Faber is Professor of Neuromuscular Disorders at Maastricht University.
Thank you very much. Dear candidate, I would like to congratulate you with the work you have performed, and I would also like to congratulate your supervisors. And this work has been very timely to me, and I will explain you why. Because the National Regulatory Authority in the Netherlands for healthcare works since last year with so-called improvement goals. And one of the improvement goals is reduction in restraint use. So I think you will easily understand what I was very interested when I got this thesis. And I thought, well, now I know what to do, which is not entirely true, but I think you did very good work, which will help us on the next steps. I'm pretty sure about that. I would like to continue with the first opponent, because there were some differences between the countries, and I was a little bit surprised by the difference in patient or family request for restraint use, because I thought I've never seen a patient asking for restraint use. Can you explain this?
Highly esteemed opponent, thank you for the compliments and the questions. Yes, this was also surprising to me to see this difference. What we also realized that this answer option isn't really a valuable one, because it would be very different whether a patient asked for it, for example, for a bed rail, that because he fears to fall out of bed, or whether the relatives asked for the restraint because they they do not trust the decision of health professionals. But we do not have closer information why these big differences are, so this would have to be investigated. Yes.
It would require a little bit more study then. Yeah. Okay, and in your study, most of the interventions are initiated by nurses, which is of course logical, but I wondered, should there be a role for the physician and a responsibility for the physician?
Yes, the physicians are in many countries still responsible for patient care, and especially for the documentation. For example, in Switzerland, there are some hospitals now changing their guidelines so that every restraint, even if it's a sensor mat, a kind of electronic restraint, must be prescribed by a physician. So they are really also, they have responsibilities in it.
But they were not involved in these questionnaires, so we are not informed on the ideas and attitudes of the physicians in this regard.
No. This is missing, and this is also a thing that is missing in many studies. Most of them focused on the nursing profession, but I think especially the physicians have an important role, and they should really be more involved in this topic.
Well, considering that they work as a team, or they should work as a team, I think that's important. Do you think that the attitude of the physicians will be very different from the nurses, or do you assume, as you answered already, that they have the same sort of social background within their hospital?
I think it would be similar. We did also another study where physicians and physiotherapists were involved, and there we saw that there was no difference between healthcare professions. So, it might also be related to the instrument use, so that it was hardly to get a really refined picture where we could identify differences.
And now that we will start with some kind of a project to reduce restraints. And what would you advise to us? What should we do as a first step, for example?
As a first step, I would highly recommend that the processes are systematically implemented. And after that, I think it's easier to start with the evaluation when their evaluation took place, that to change the decision there than to change the initial decision to use restraints. Because what we saw also in our study, or also that we know from literature, it's often a stressful situation where nurses or physicians have to make a decision, and I think it's harder to achieve a change in this initial decision than when they start to evaluating the restraint use. So it might be easier to start there. Of course, it would be better if we use no restraint, when we can achieve that they never decide for restraints. But maybe it's easier to start with the evaluation for this change process than to start with this first decision.
And then the idea is that if you evaluate it, you can improve knowledge and you can change beliefs Okay.
You can stimulate new experiences when you stop restraint use earlier, that it's also safe without restraint, so that then you can go to the initial decision. But it's just my opinion, or what I found based on my thesis. But yeah, I think this is an easier start in direct practice than to change the whole process.
Okay. I have one more question, if I may. Yeah. You have focused on adults, especially on elderly adults, and as you said, they were mostly the vulnerable people. Another vulnerable category in the hospital are children, and also in children restraints are used. Do you have any recommendations on that? Did you read anything about that? Because I know that's not the topic of your thesis, but...
Yes, I read also, or I discussed also with health professionals about restraint use in pediatric care. And it really depends to whom I talked, how often restraints are used. But what I was made aware of is that in pediatric care there is a better involvement of the relatives. So sometimes they can involve the relatives so that they do not need to use restraints. And this is also one of my conclusions that it might be very valuable to involve relatives more systematically to also accompany the patient during his journey in the hospital. And I think in general it might be worth to start to learn from each other, because I think in pediatric care they have different ways or different ideas that never came up in adult care.
For example, more rooming in, something like rooming in, so that the relatives stay at night with the patient.
Yes.
Yeah. Okay, thank you very much. I give the word back.
Thank you. The opposition will be continued by Professor Haak. Professor Haak is Professor of Internal Medicine at Maastricht University.
Thank you. Dear candidate, congratulations for your thesis, great work, and also congratulations to the supervisory team. It's an interesting and important subject, restraint in acute hospitals. I recognize the clinical practice as specialist in internal medicine in acute hospital. So restraints are actually a violation of human rights. And it's used in hospitals studied around in 8 to 10% of the patients, as I get from your thesis. First, I would like to ask you if you are confident of the numbers of restraints used in hospitals you studied in the chapters 2, 3, and 6. The data from LPZ questionnaires are about 30,000 patients, is that correct?
Yes, this is correct.
Okay, and about 25% of the patients were not included because they were not available or cognitive impaired and not really able to say, yes, I can go. So those patients who were not there or could not be included, they probably were also restrained because of the cognitive impairment. Don't you think so?
Highly esteemed opponent, thank you very much for this question. Yes, I totally agree. I think that the prevalence and also maybe the vulnerability of the patient is underestimated in this thesis, because we have this 25% of patients that didn't participate because we didn't investigate it why, we know that most of them didn't participate because there was no consent. Therefore I totally agree that I expect that the results are underestimated.
Yeah, no clue how much underestimation there is, of course.
That I didn't analyze in my thesis.
Is the LPZ a solid way solid methods to study the restraints?
Do you ask whether this is a good method to investigate restraint use? I think since we saw that that only 2/3 of all restraints were documented, I think it's very valuable to go to the patient's bedside and to see what is happening there. Okay. So I think we have this benefit using the LPZ method, but we have also the limitation of this 25%. Yeah. And this limitation, if we would use the patient documentation, for example, we wouldn't have this limitation with this 25% of missing patient if they all gave a general consent. But we would maybe miss the 1/3 restraint that was nowhere documented.
Okay, but because Switzerland and Austria could be included with the LPZ, and the LPZ is used also in the Netherlands, Great Britain, and Turkey, but the data were too low and you couldn't include them. What does that say on the LPZ?
Yes, there were in the other countries there no or only very few hospitals participated. This was the reason why we didn't include their data. And yes, it also says that the investments, the personal effort to collect data might be too high. Therefore, for example, we in Switzerland, we are now investigating also other methods to use more the patient documentation. For the moment, more for falls and pressure ulcers, because we know that they are more established in practice, that there we have a better documentation quality compared to restraints, for example.
Okay, but we can use the LPZ like you did.
Sorry?
We can use the LPZ like you did in Switzerland and Austria.
I think it's better than to have no data, but of course, improvement is always possible.
I agree with you. However, in chapter 4, a very interesting chapter, I would say, the outsider observations, I was a bit worried about the observations. So it was a bit up and down during the day, restraint by the one nurse and no restraint by the other nurse, and the registration was yes or no. It was a totally Russian roulette, I would say. Can you comment on that?
It was also a very interesting study for me, and I think a very valuable study also for getting a different insight, especially also to see these differences, how it is handled in practice, so that we could see that there are differences depending on the nurse, that some nurses are more experienced, or maybe they have a different attitude that could not be measured, that they are more critical about restraint use, or that they also experience more negative effects of restraint use. Does this answer your question? I'm not sure about.
I think it's yes, on the road, but was this in a hospital where there was a guideline, and were there refresher courses, because that was one of the things that was important for the restraint use or not use?
That I didn't investigate it systematically, but I know that in this hospital they had a guideline, but not a very differentiated one, so they revised it just, the guideline was under revision while I did this study. And as far as I'm informed, but I didn't collect this data systematically, there was no regular refresher course available for the nursing staff.
So what I get from your studies is that there is a high amount of restraints, more than 10%, because of the missing values because of 25%, and of the bad registration and the up and down restraints during the attitude of the nurses, perhaps, also the physicians, perhaps. This is my impression. Is that correct?
Yes, that we have big differences depending on the staff, on the individual staff that decides, but also what happened on a meso level. So what are the structures within an institution?
Okay. Can I have one more question? No.
Great.
Thank you very much for the answers. I'll give the word back to the prorector.
Thank you very much. The opposition will be continued by Professor Loorman. She's Professor of Nursing Science at the Medical University of Graz in Austria.
Thank you,
Welcome here, and we're glad you're able to participate in this ceremony.
Thank you very much, Mrs. Prorector. So, dear candidate, of course, I have also read your thesis with great interest, and my compliments to you and to your supervisors. But I have to admit, after reading your thesis, I realized that I have also used many times restraints out of routine as a nurse, but of course this is long ago, so you still have shown in your studies that it's still a fact in hospitals. So again, congratulations and thank you that you have investigated this important topic. The candidate, let's look to the very near future. As we all know, at the moment, we have a lot of problems in the health facilities because of the shortage of nurses. So therefore, pragmatic solutions are needed. So when I'm looking to your chapter 4, you are stating several times, but especially in chapter 4, that the decision on restraint use is executed unconsciously, and that restraints are often used when the burden of the nurses is high or the situations are overwhelming. So I think all this is the case in hospitals on a daily basis. And then in chapter 7, you recommend that the management should decide to remove restraints material. So the solution for me seems simple: for restraint-free care or not.
Highly esteemed opponent, thank you very much for the compliment and the question. You are asking whether it is recommended to just remove the restraint equipment, so then we do not use restraints anymore.
Yeah. For example, next week, a manager would ask you, Mrs. Dr. Thomann, please give me a solution to solve this actual current situation with a shortage of nurses. We must find a solution not to use restraints.
As I understood, there are like two different questions. The one is about removing the equipment. Regarding this point, we still do not have evidence that restraints are effective. So why we are using them? So we could remove it and see what happened, but I think this wouldn't be possible within the existing structures, because also management is under high pressure if a negative patient outcome happen. Also from a financial point of view, in many healthcare systems, you do not get additional money if a negative effect happen. And regarding the staff shortage, there is evidence available that there is that restraint use and staff shortage are related. But what we also saw in our studies, especially in chapter 4, is that many nurses already use, for example, preventive measures to prevent restraint use, but they do not use them in a purposefully and in a systematic manner. So I think within the existing structures, it would be already possible to achieve a change.
So you think the current situation is comparable to the time when you did your studies?
I
because
do not know.
You recommend that they are using other things
Yeah.
to prevent restraint. So do you think that is nowadays, let's say today, possible?
I think yes, because the things I could observe, I think nurses are still doing these tasks. So, and regarding the staff shortage, we also know that using restraints also requires time. So I think it's the case with with any topic where we should use more preventive methods. It's more you invest in initially a bit more time, but then you save a lot. For example, if you can prevent a patient getting a more strong delirium, you save a lot of time afterwards. So I think it's kind of a rethinking that is not only for restraint, but also with other topics.
Okay, thank you very much. So I have another question. I would like to come to the aspect of education and to cite you precisely. You said education has a great responsibility in the socialization of nurses. Yeah? And in chapter 4 of your thesis, for example, you mentioned that it is essential to improve the evidence on restraint use in hospitals, to teach it, and to implement findings in practice. I'm correct?
Yes.
But later on in chapter 7, you are saying that there is a lack of effective evidence-based restraint reduction strategies for the hospital setting. And then later on, you suggest to make evidence-based education about restraints use in hospital mandatory in nursing and health professional curriculum. So I'm wondering, what will be the content of your education then? On the one hand, you have less of evidence-based knowledge, and on the other hand, you recommend evidence-based education.
Thank you very much. Evidence is growing, so we have more and more evidence available. There are still effective reduction strategies lacking, what also was found by a Cochrane review. But there are other things that we already know. For example, the ethical and legal processes like a regular evaluation or the use of alternatives, they are already here. So we know that we should do this, but we saw that it is not systematically implemented. So to show why it is important to implement these processes and why to fulfill them. For example, that it is clear that a nurse or a physician must show that what kind of alternative or preventive measures were used beforehand before they are even allowed to use a restraint.
And one short last question, is it okay? Thank you very much.
Thank you.
Thank you so much. The opposition will be continued by Dr. Blijlevens. He's assistant professor at the Department of Health Services Research of Maastricht University.
Thank you, Prorector. Dear candidate, first of all, I would like to congratulate you on your well-written and valuable dissertation. And of course, I would like to involve your team in this congratulations as well. And as Professor Hamers already mentioned, you may have been noticing that we have been researching restraints for almost 25 years here at this university within the Living Lab in Aging and Long-Term Care. And during this period, we explored the prevalence of restraint in both nursing homes as well as home care. We explored factors which are associated with the use of restraints and developed interventions to reduce and prevent the use of restraints in both settings. And we are very happy that the arm of Maastricht by Sandra is reaching to Switzerland, and that you're now doing this kind of studies within the hospital. And still is, after all these years, it's an important topic. And restraint use can be considered as inappropriate care for several reasons, and you mentioned them all in your introduction. However, and you see it in your prevalence study, as well as we have been seeing it in our studies in home care and nursing home settings, the prevalence of restraint use is still high, so we haven't won the battle yet. And I would like to have a closer look on chapter 5, also on the attitude study with you. And you used an adapted version of in our research team developed Maastricht Attitude Questionnaire, the MEQ. And this was originally developed to assess nurses' attitudes and opinions toward physical restraint use. And you used a rather broader definition of restraints. And you also included sedative medication, psychotropic medication in general. And then I'm a little bit surprised, but when I look into table 3, on page 123 of your thesis in chapter 5, I see that you most often use the term physical restraint and not the term restraints. So can you please share some ideas with me whether you really assessed nursing opinions about restraints in general and more specific about opinions about sedative medication?
Esteemed opponent, thank you very much for the compliments and the question. We aimed not to develop the scale, and therefore we tried to stick very close to the version that was already translated by colleagues into German. So therefore we only adapted. We changed from resident to patient and from nursing home to hospital, but everything else we stayed as it was. So we used the German version where it was asked about freiheitseinschränkende Maßnahmen that more correspond to the term restraint, but then for the article we used the version as it was in English. So,
but then is it clear for those nurses you questioned? Is it clear for them that you are talking also about sedative medication?
The questionnaire, the MEQ consisted of different scales. So we had also the scale about discomfort and restrictiveness, and there, for example, the pharmacological restraints are missing so far. So no, we didn't include this separately. So this would be another limitation that wasn't mentioned so far, yes.
Good. Second, I was wondering why you didn't include other disciplines in your study. In your introduction, you argue that nursing staff plays crucial roles in this decision-making process. However, my question is, do they really decide upon the use of restraints? And isn't the physician more in the place to make the decision? So please philosophate together with me about your reason not taking into account the attitudes of physicians, for example, but also maybe physical therapists or occupational therapists.
Thank you for this question. Whether nurses are really deciding, I think there is a lot of evidence that's suggesting this assumption that nurses decide so far, and I think we there have kind of a gap between theory and practice. In theory, it's a physician that is responsible, that should do this decision, but in practice, often it's the nurse, and then the nurse just asks the physician, "Can you give me your signature that you are that you agree with that?" So,
do you really think that that's the case? That
yes,
these nurses are deciding? Because what we saw in previous studies we have done in the Netherlands is that when we try to educate nurses and help them with reducing the use of physical restraints, we saw that that didn't work because one of the reasons was that approaching of, or better coming to the reduction of physical restraints or restraints in general, that it is a multifactorial and multidisciplinary problem. So we have to involve other disciplines. So what's your opinion about that?
Based on our findings, there are differences on which restraint type we are addressing. While for fixation with a belt, also what we found, there is most often the physician in the lead. But when we talk about other restraints, like a sensor mat or a bed rail, most often the nurses are in the lead. So I think we have there also a differences depending on restraint type. But I totally agree with your opinion that all professions should be involved in further research. So because what we also saw in this thesis is that the institutional culture has an important role, and changing a culture also depends on the physician and everyone involved in this practice. So I totally agree that it should be an professional approach taken.
Thank you. I think we're out of time. Okay, then I give the word back to the pro-rector. Thank you.
Thank you. Well, it's time for the last opponent, Professor Scholz, Professor of Old Age Medicine at Maastricht University.
Thank you, Pro-Rector. Dear candidate, congratulations. Perfect work. And also for your supervisors. Already the second time today. When does this stop? I have a few minutes, but I want to test both of your paranymphs. But the focus is, of course, on you. I would like to ask one of the paranymphs to read Proposition 9.
So, Proposition 9. Nursing research must integrate more health economic aspects in order to gain influence.
Thank you. We already learned during your defense that there remain a lot of questions after you finish this thesis. So a lot of evidence must be gained. And that's why I would like you to reconsider this proposition. And I made another one, and I hope you will agree with that. And because I think it should be nursing research needs a much larger evidence base and must also integrate health economic aspects in order to become value-based as well. Isn't that a much better one?
I totally agree, yes.
You agree?
Yes, I agree.
Okay. So we agree on this evidence base, because this is one of the strong points of this Maastricht Graz Bern program, that we really contribute to evidence. Thank you. It's enough. It's enough. Then I come to my main question. This question is also related to Chapter 3, in which you conclude that restraint use varies widely among hospitals, and that this finding emphasizes earlier assumptions that routine and institutional culture plays a role in restraint use. Routine and culture. But then I do not read anything about culture anymore. And you conclude, to solve these problems, we have to invest in structures and staff knowledge. Why not in culture? And recently I learned from a professor who is much better in it than I, that she defined culture as shared beliefs which can help to understand shared behaviors. In, for instance, using restraints. What strategy should we use to change shared false beliefs regarding restraint use in hospitals?
Thank you very much for this question. I think the topic restraint is a very emotional topic. So maybe just addressing the cognitive way might be not effective. So it might be that to achieving such a change, we might address more the experiences, so that staff can experience that restraint-free care is effective and safe. So I think, does this answer your question?
I do not hear anything about communication. Why do we do the things such as we do them every day? What are the beliefs? What do we expect from restraints? Are these false beliefs, or are they? What's the motivation to use it? What kind of communication do we need?
Regarding your first question, I think there are many false beliefs that restraints are effective. For example, fall prevention, even though there is no evidence so far that this is the case. And regarding your second question, what this has to do with communication?
Yeah, within teams, together with the family, with patients.
I think so far, also based on the findings of this thesis, there is such a strong component of this routine or kind of implicit standards that there's almost no communication about it, especially with the patients or also the relatives. So as demonstrated in one observation I cited in my article, there we could see that because I was there observing the nurse, she asked the patient whether he likes the bed rail. And then he said, no, I think it's not really necessary, it's okay without. But I think such kind of shared decision making not often takes place when it goes for restraint reduction or restraint use, I'm sorry.
Okay. Can you ask the second para-nymph to come to the microphone? Because I want her to read proposition 5.
Lower management needs to be better trained, master's degree as an example, to achieve better patient care.
Okay. Dear candidate, we know that changing beliefs, attitude and performance of healthcare professionals is a hell of a job, huh? And it requires leadership also from the management. Huh? And regarding this proposition, what competences should managers achieve to support nurses to be more relaxed when they wouldn't use restraints?
I think they should start sharing the risk when they decide against restraint use. That would be one point, but also taking the responsibility to discuss restraint use in an interprofessional vessel, for example. Also to show, to take this leadership skill, not the nurse has to say, no, I think it's not adequate to make a hand fixation for an intubated patient, but that this role takes the nursing management.
Silvia Thomann, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company await the results of our deliberations and our return in this room.
Please all rise.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
Long road to the south side. 7 miles in my rearview mirror, I know what it felt like. My goals only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. All your time, 'cause I'll go the extra mile. Long road to the south side, 7 miles in my rearview mirror, I know what it felt like. My goals only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. On the dash, got my laces tied. Long road, I don't waste no time. Break rules because fate decides. With the team and we chase the light. I make a move, fall down, shake it off. I hate to lose, bad branch, break it off. No room for negativity, praise and love. Prepare for deep part cause we're taking off. Get the mileage, traveling so far from home. Gathering knowledge, future that we go for. And even though these nights seem long, I know that I am never on my own. Know you've won the battle once you've grown. South side, 10 miles in my rearview mirror. I know what it felt like. My goal's only getting clearer. East side to the west side, no place like home. If it's questions that you've got, go the extra mile and die. Long road to the south side, 10 miles in my rearview mirror. I know what it felt like. My goal's only getting clearer. East side to the west side, no place like home. If it's questions that you've got, go the extra mile and die. Years can't fly by now, don't waste all your time. 'Cause I'll go the extra mile.
Silvia Thomann. The degree committee here present has assessed the quality of your thesis and your defense. In view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Zwakhale is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor.
Please all rise. Dear Silvia, yeah, you know it from before, so you have to make a promise first. Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
Yes, I promise.
By the authority vested in us by law and conformity with the decision of the committee here present, I hereby confer upon you, Silvia Thomann, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, I now present you with a degree certificate signed by the rector, the secretary, and all the other members of the committee, and affixed with the official seal of Maastricht University. They make it so big. Congratulations, Silvia. You did so well. Dear Silvia, it's up to me to speak with you about the Ludesio, so congratulations. First of all, I think you did great. Sabina and I are extremely proud of you. And also, of course, to start with, on behalf of us, we would like to congratulate your friends and family who are here today and who supported you throughout this PhD trajectory. Your PhD journey finishes here today, and a journey which started for us only 4 years ago, in 2019, March, so exactly 4 years ago. This was the time that we first met during the PhD program. And the PhD program, for you, those of you who don't know, was established almost, over 20 years ago by founding fathers Theo Dasse and Ruud Halfens, who is here at the room, and later on, of course, also, shortly afterwards, Christa Lohrmann. Not as a founding father, of course, but it was too much. The program alternates in Bern, Graz, and Maastricht, and includes also regular conferences organized for PhD students by PhD students. And last year, in 2022, the 19th EDCNS conference was organized. The theme of the conference was Nurses Taking the Lead. And without any doubt, you are a real-life example of this. You took the lead. Silvia, you were the driving force together with your fellow students as head of the organizing committee. And indeed, I mentioned that your journey only started 4 years ago. It sounds like a real long time, but it is a real achievement, exceptional. Also, especially since your life was not fully dedicated to your PhD. You did many other tasks. As a part-time PhD student, you've been teaching numerous students, bachelor and masters at the University of Applied Science in Bern. And since a few years, you also held a more management position in Bern. And you're involved in acquisition, conducting research, implementing research, many things around. So quality in healthcare is a daily business for you, I think. And you are an example of how you combine nursing practice with education and research. So I think that's a real achievement. Sylvia, in writing this laudatio, I was thinking about things that characterize you. And I came up with some words. And these include, for me, these are my words, trustworthy, helpful, friendly, calm, modest, and a bit impatient. And I will explain a bit more about that. This morning, when we had a city walk, I also asked your fellow students. And they came up with on point, pragmatic, calm, a bit cynic, relaxed, and chill. For me, trustworthy is the word, since I can't remember one meeting that we had that you weren't there or well prepared or whatever. You always was there. And when you said you'd done something, you always done it. So even during when we had COVID-19, we met online, you were always there, you were always making progress, so it was really trustworthy. Helpful and friendly, you always were, especially for your fellow students. I think active participation and willingness to help others with your experience was always there. Calm, that was a word that was mentioned a lot and often. It seems that you're always in control. You were well prepared, had an overview of all the things that needed to be done, and just did them. Okay? Modest. I think you're not the lion in the room. You're not shouting, or the things that you mentioned are always relevant and balanced, never too much, never too less, and your modest attitude is typical. And then, impatient. And I thought this morning someone mentioned pragmatic, and pragmatic might be a better word, because you're typically a quantitative researcher. Good friends with data, friends with statistics and SPSS, but ask Silvia to do an in-depth qualitative study, and this will cost you much more effort. However, you did. But I also remember our last meeting in Graz when we were divided in two groups, and we did an exercise on the values and the outcomes of the PhD program. What are the working mechanisms? What are the key values? And as you probably remember, we had some questions, and you all used sticky notes to, well, put down keywords. Well, after you brainstormed and finished these notes, a qualitative analysis was done. Well, who was in the lead? Yes, Silvia, and it was obvious. Silvia clustered in no time the things that were connected to each other and done. The things that didn't fit, these were not important, because they didn't fit. The impatientness was obvious, or the pragmatic approach might be a better name. Yeah, what's in a name, what's in wording? We can elaborate on this for days, but why? So, but not with Silvia around. This was case closed. But this is exactly, I think, why you completed a PhD in 4 years and published all articles meanwhile. You were always, or it seemed like you were always in control. We submitted also some symposia. One was for the GSA, I still remember, a few years ago, and unfortunately we couldn't go due to COVID. But your contribution to various other conferences was evident, and you also managed to publish various other articles which were not part of your thesis, with as a co-author, as a first author in peer-reviewed and other professional journal. I was actually impressed when I saw the list at the end of your booklet. I wasn't actually aware of all these articles apart from your PhD. Modest, as I said. Dear Silvia, Sabine and I will look forward to your next career steps, because we know the best is yet to come. It may be a long road to restraint-free care, but with your ambition and your passion, it's in good hands. We do wish you all the best for your future career and personal life with your beloved ones. I'm really proud of you, but also of Christoph, who was here earlier today. You had the wish to be here together today to do your defenses on the same day, and you succeeded both in that. And so I was very pleased that you were both my first PhD students in the program of Bern Graz Maastricht. I couldn't have been more lucky with you, and I truly will miss our relaxing meetings.
Thank you.
Dear Dr. Thomann, also on behalf of Maastricht University, I congratulate you with the degree you have acquired. I can say that the committee was very satisfied with the way you defended your thesis, and we were impressed by your relaxed appearance. I don't know whether you felt as relaxed inside, but outside was really very relaxed. And I hope you go home with a good feeling about this PhD defense, because that's what you deserved. And I wish you success with your future career. I'd also like to congratulate, of course, your family and friends and colleagues with this degree, and your supervising team with a beautiful PhD defense. And I'd like to thank the members of the Corona today for being here, especially our guests from outside Maastricht, Professor Moore and Professor Loorman. Very happy that you could be here in person, live, because lately that isn't always the case, but it's nice to have everyone here for the ceremony. Thank you very much, and of course also thank you for your effort and time to be here. With that, we have come to an end of this PhD ceremony, and I close this academic session.